Here's a question that should make you uncomfortable. When researchers test new pain medication, new surgical techniques, new treatment protocols, who are they testing them on? For most of the modern medicine history, the answer was men. The pain medication you take tested primarily on men. The surgical technique used on your hip developed and refined on a male patient. The physical therapy protocol is based on research with a male subject, then applied to women with the assumption it would work the same way, but it doesn't. In 1993, NIH finally required researchers to include women in clinical trials. That was only 33 years ago, I'm making this in 2026. Before that, for decades, in modern medical research, women were systematically excluded. And the reason? Women hormone cycles make research messy. Pregnancy is a confounding variable. Menopause complicates things. In translation, women's bodies are too complicated. So let's just study men and assume the results apply to everyone. This created a massive gap in medical knowledge, a gap that still exists today, because 33 years isn't enough time to fill in 50 plus years of missing research, especially when the research that is being done on women often doesn't ask the right questions, doesn't look at the right outcomes, doesn't get funded as well as other researches. The result is women's pain remains invisible in the research that should be making it visible. So let's start with how this even happens. In the early days of modern clinical research in the 1940s through the 1960s, there were no formal requirements about who to include in studies. Researchers chose whatever subject were convenient and available. Who was convenient? Medical students, mostly males, hospital patients, often males, military personnel, exclusively males, and prison population, overwhelmingly males. Research was done on whoever was accessible. Then in the 1960s, the thalidomide disaster happened. That was a drug prescribed to pregnant women for morning sickness. It caused severe birth defects in thousands of babies. It hadn't been adequately tested on pregnant women before being prescribed to them. Regulations followed. In 1977, the FDA issued guidelines excluding women of childbearing potential from early phased drug trials. And the reasoning was to protect the fetus from unknown drug effects, which resulted women were excluded from most drug research. The risk of pregnancy becoming the reason to exclude all women of childbearing age, even if they weren't pregnant, even if they were using contraceptions, even if they had no intention of even getting pregnant. The assumption any women could potentially become pregnant, so exclude all women. This policy lasted 16 years or so. Before, from 1970 to 1993, women were systematically excluded from most clinical researches by official policy. During this time, major advances happened. Drug development, surgical techniques, treatment protocols, diagnostic criteria, clinical guidelines, all based primarily on male subjects. In 1993, Revitalization Act was passed. It required NIH-funded research to include women and minorities. Finally, women had to be included, but several problems remain. This only applied to NIH-funded research. Pharmaceutical and medical devices research wasn't required to follow these guidelines. It didn't require analyzing results by sex. You could include women in your studies, but not analyze whether the treatment worked differently for women versus men. No penalties for noncompliance. Researchers could effectively ignore it without consequences. It didn't address the backlog. Decades of research done entirely on men didn't suddenly become invalid or get redone with women included. All the medical knowledge, guidelines, and practices built on the research remain in place. In 2016, the NIH strengthened its policy, now required to consider sex as biological variables in research designed and analyzed better, but still only apply to NIH-funded research. It doesn't fit the existing knowledge gap from decades of male-only research. Let's put this into perspective. In 1940 to 1977, women, sometimes included, often not, no requirements. 1977 to 1993, women actively excluded by policy. From 1993 to 2016, women required to be included, but analysis of sex difference was optional. 2016 to present, sex differences required to be analyzed in NIH-funded research. Most of the modern medicine was developed during the first 76 years of that timeline. Women were largely absent or their differences were ignored. Now let's get specific about pain research. How is pain studied in research setting? Often started with animal models. So guess which animals were primarily used in pain research through the male rats and mice? Why? Because female animals have like menstrual cycles. Researchers considered this confounding variable. Easier to use male animals. Their hormones are relatively stable. Results are cleaner, but then you're studied pain mechanism in male animals. And applying those findings to both male and female humans, a 2014 study showed something important. Pain mechanisms differ by sex, even in mice. Male and female mice use different immune cells to process pain signals, meaning decades of pain research done on male mice might not apply to female mice or women. In human pain research, clinical trials for pain medication historically used more male subjects. In 2001, analysis of clinical pain trials found only 20% of students reported sex-based analysis. Of studies with adequate numbers of women, most didn't analyze sex differences. Drug dosing was calculated based on average body weight, not accounting for metabolic differences. What this means, you take a pain medication. The dosing is based on average male metabolism and body composition, but your hormone cycle affects how you metabolize that drug. It may be more effective at certain times of your cycle, but less effective at others. You may experience different side effects than male patients, but the prescription guideline doesn't account for any of this because the original research didn't study it. Specific to musculoskeletal pain, historically, sport injury research focused on male athletes. This made sense initially. Men's professional sports had more funding, more attention, and more injuries being documented. Research on ACL injuries, rotator cuff tears, hip labrum tears, mostly in male athletes. Treatment protocols developed based on this research. When women got the same injury, same protocols were used. But women's injuries often happened way differently. Biomechanical differences would be the Q angle, hip to knee angle, ligament elasticity, muscle recruitment patterns, hip width, and joint angles. These are affected. These affect both injury risk and recovery trajectory. But rehabilitation protocols didn't account for these sex differences until relatively recently. And this still not standard everywhere. Pregnancy-related musculoskeletal pains, this is where the research gap is most obvious. Pregnancy is a uniquely female experience. Obviously, can't study it on male subjects. So how much research exists on pregnancy-related musculoskeletal changes and pain? Comparatively, very little. Let's look at the research funding. NIH funds in This is 2023 data. Sports-related injuries is about $150 million. Lower back pain general is about $180 million. Arthritis research is about $500+ million. Pregnancy-related musculoskeletal disorders, about $12 million. Postpartum pain and dysfunction is roughly around $8 million. The disparity is obvious. Pregnancy affects about 3.6 million women in the US annually. Majority experience musculoskeletal pain during or after pregnancy, but research funding is minimal compared to conditions affecting fewer people. Why? Multiple factors. Pregnancy-related pain not seen as serious medical condition. Normalized as part of pregnancy. No pharmaceutical market, so drug risking during pregnancy, split across medical specialties. So you got obstetric, you got orthopedic, physical medicine. So nobody really owns it, which results are we have limited high quality research on long-term effects of pregnancy on musculoskeletal systems, optimal postpartum rehabilitation protocols, prevention strategies for pregnancy-related pain, which women are at higher risk, how to predict who will have chronic issues, and best timing for intervention. So doctors practice without strong evidence based on postpartum musculoskeletal care. Now let's talk about how women's pain is studied differently and believed differently than men's pain. There's actually a lot of research on sex differences in pain. Consistent findings. Women report higher pain levels than men for same conditions. Women have higher pain rate of chronic pain conditions. Women's pain is more likely to become chronic after injury. These are established facts. But here's the question. How is this interpreted? There are two ways to interpret this data. Either women's pain are different and more required different treatment approaches, or women are more sensitive to pain. Women complain more. Women have low pain tolerance. So guess which interpretation has been more common in medical culture? Historically, there's been a bias towards the second one. Women are more emotional about pain. Women catastrophize. Women have low pain threshold. These phrases actually appear in medical literature and textbooks. The implication, the pain isn't as real or severe as women report. It's psychological or exaggerated. This often affects how women's pain is treated. In a 2001 study published in the Journal of Law, Medicine, and Ethics, women pain reports were taken less seriously than men. Women wait time longer for pain medication in ERs. Women were more likely to be given sedatives instead of pain medication. Women's pain was more likely to become attributed to emotional or physiological causes. A 2008 study in Academic Emergency Medicine, women with acute abdominal pain waited 33% longer than men to receive pain medication. A 2018 study, healthcare providers watched videos of patients experiencing pain. They rated women's pain a less intense than men's pain, even when women and men showed identical pain behaviors. This was true even among female healthcare providers. This is implicit bias, unconscious assumption affecting judgment. Nobody thinks they're doing this, but the data shows it happens systematically. In chronic pain, specifically, women's chronic pain is more likely attributed to physiological factors. Women are more likely to become prescribed antidepressants or anti-anxiety medication for pain, not necessarily because they're more depressed, but because their pain is perceived as psychological. Men's chronic pain is more likely to become attributed to physical causes and treatment with physical intervention. But why does this happen? Historical medical views of women being back century hysteria was considered a female condition. Basically, any symptom without obvious physical cause. Women's bodies were considered mysterious and prone to psychological problems. Women were believed to be more emotional and less relatable reporters of their own experience. These ideas persist in subtle ways in medical culture, combined with the research gap where we actually don't have a good data on women's pain mechanisms. This creates the perfect storm. We don't fully understand women's pain psychology because it wasn't studied. So when women's pain doesn't fit the male model, it gets attributed psychology rather than acknowledging that the model might be incomplete. So what specific research is missing that would help women with pain? Let me be specific. We don't know because it hasn't been adequately studied. We know hormones fluctuate throughout the menstrual cycle. We know this affects ligament elasticity, inflammation, pain sensitivity, muscle recovery, coordination, and motor control. What we don't know well is how do these hormones fluctuate affect injury risk day to day? Should rehabilitation protocols differ based on cycle phase? Do pain medication work differently at different cycle phases? Should exercise progression account for hormone cycles? How do hormone contraceptives affect all of this? Some research exists on these topics, especially regarding ACL injury risk, but it's not comprehensive and it hasn't been translated into a clinical practice. Orthopedist doesn't ask where you are in your cycle when prescribing treatment. Physical therapy protocols don't adjust based on hormonal status because the research based is insignificant to creating evidence-based guidelines. We know about the short-term changes during and immediately after pregnancy, but long-term effects years after pregnancy, largely understudied. Questions without good answers. Do biomechanic changes fully reserve or are some permanent? How many years postpartum do hormones affect a ligament persist? Does each subsequent pregnancy create compound effects? Which women are high risk for chronic dysfunction? What's the optimal rehabilitation timeline? Can we predict who will have problems? What preventative strategies actually work? Research that exists are small studies, short-term follow-ups, usually only 6 to 12 months postpartum, if you're lucky. Limited outcome measures often doesn't look at function, just the structure. Research we need are long-scale, long-term studies, so 5 to 10 years postpartum, functional outcomes, prevention trial studies, rehab intervention trials, and predictive modeling. This research is extensive and it takes years, requires sustained funding, which hasn't been prioritized because pregnancy-related musculoskeletal issues aren't considered serious enough. Take hip arthroscopy as an example. Common surgery for hip labrum tear and FAI. Research on outcome has been published, but how much of it analyzes outcome by sex? Very little until recently. A 2019 study looked at hip arthroscopic outcome by sex. Women had different preoperative pain patterns. Women had slightly worse outcomes at 2 years. Women were more likely to have persistent pain. Why? The study couldn't answer that because the surgical technique, rehab protocols, and patient selection weren't designed with sex different in mind. Nobody had studied whether the surgical technique or the post-op rehab should differ for women. Everyone got the same surgery and the same rehab protocol. This is true for most orthopedic treatments, developed and refined primarily on male patients, applied to women with assumption of equal effectiveness. The outcomes rarely analyzed by sex until recently. This is particularly big gap for women's hip pain. Clinical observation from pelvic floor physical therapy, hip pain have pelvic floor dysfunction. When you address the pelvic floor dysfunction, hip pain often improves. High quality research on this is very limited. Small case series or pilot study, no large randomized controlled trials, no standardized assessment protocols, no evidence-based treatment guidelines. Why hasn't these been studied more? Because the causes specific boundaries. Pelvic floor in women's health PT specialties, hip pain is orthopedic specialty. Funding is often studied by specialties. This interdisciplinary question falls between cracks. This is a fundamental question. When imaging is normal, but the pain is severe, what's the mechanism? We call it functional pain or non-specific pain. But that's not an explanation. That's a label for we don't know. But what we need is better diagnostic criteria for functional movement dysfunction, validated assessment tools, understanding of mechanism, evidence-based treatment protocols, and outcome measures specific for functional pain. Some research exists in sports medicine and rehab science, but not comprehensive or specific to women postpartum hip pain. Why is all this research missing? Let's talk about why this research doesn't even get done. How research funding works is research has an idea for a study, writes a detailed grant proposal, submits it to funding agencies, so NIH, private foundations, etc., competes with thousands of other protocols, competes with thousands of other proposals, review panel of other researchers decides what gets funded. Funding decisions based on scientific significance, innovation, impact on public health, feasibility, investigator qualifications, institutional support. Women's musculoskeletal pain research doesn't score as high as other topics on these criteria. But why? It's not life-threatening. Cancer, heart disease, Alzheimer's, these are life-threatening and get priority. Hip pain won't kill you. So it's lower priority for funding. Even though the quality of life is impacted hugely, it's difficult to study. Pregnancy-related questions are inherently complex. Can't randomly assign women to get pregnant or not. Long-term follow-up periods needed, years, many confounding variables, and ethical constraints. Requires large sample size to detect the differences. Expensive and time-consuming. Grant reviewers see this and think difficult, expensive, long timeline. It's a risky investment. It's interdisciplinary, crosses obstetric, orthopedic, physical therapy, pain science, but funding mechanisms are often specialty specific. Falls between categories. Reviewers from one specialty may not see it as centered to their field. Lack of strong advocacy and lobbying. Diseases with strong patient advocacy, organizations get more research funding. Examples would be breast cancer has powerful advocacy organizations that lobby for research funding. Pregnancy-related musculoskeletal pain has no equivalent advocacy organization with political. Women suffer individually, not organized collective around this issue. Low commercial interest. Pharmaceutical companies fund a lot of the medical research. They fund research on conditions where they can develop and sell drugs. Women-related musculoskeletal pain can't give many drugs during pregnancy, and non-pharmaceutical treatment is probably the best approach in no drug market. So pharmaceutical companies don't fund this research. Medical device companies, there's no device to sell for functional rehabilitation. This treatment doesn't generate device sale. So there's limited industry funding for this research. which results the research doesn't get done. So what's the cost of this research gap? At an individual level, women suffer without clear answers or effective treatments, told nothing's wrong when imaging is normal, given treatment based on research done on men, which may not work as well for women. Pain persists. At the systematic level, doctors practice without strong evidence based for women's pain. Treatment becomes trial and error rather than evidence-based. Clinical guidelines are based primarily on male data, applied to women with assumption of equal applicability. At an economic level, ineffective treatment costs money. Years of women seeking diagnosis and treatment without resolution, lost productivity, lost workforce participation. At the cultural level, women's pain remains invisible in medical literature and consequences and consciousness, reinforcing the idea that women's pain is complicated or psychological rather than acknowledging the research simply hasn't been done. The next generation of doctors learning from research based that excluded women. The cycle continues, but it doesn't have to be. Research priority can change. Funding can be allocated to women's health research. The questions can be asked and answered. It requires recognizing this is a significant public health issue. Funding research appropriately. Training research is sex-based analysis, requiring sex-stratified reporting in all research. Long-term commitment to filling the knowledge gap. None of this is impossible. It's a choice about priorities and resources. For now, the gap remains. Women's pain invisible in their research that should be making it visible, not because women aren't in pain, but because the questions about their pain haven't been prioritized.